All right, I think we'll get started right at the top of the hour. So I know we have a lot to do this grand round session, but welcome everybody. My name's Tess King. I'm one of the chief residents here at UW. And we're gonna have a brief award session in the beginning, and then we'll turn it over to our grand round speaker, Dr. Ryan Abe. But before we get started, I will turn it to Dr. Conrad Lyles to introduce our Evans Award.
Welcome, everyone. Today, we will present our annual Robert S. Evans Awards, Bud Evans Awards, which is a real honor in the Department of Medicine. And these awards are presented every year to a graduating medical student and a second-year resident. And this award recognizes the special qualities of warmth, understanding, compassion, and concern for the needs of others, as exemplified by the life of Dr. Evans. And Dr. Evans served as the chief of medicine for a prolonged period at the Seattle VA Medical Center, and he was a beloved chief of medicine at the VA. He had a distinguished academic career, and he is known for describing a clinical syndrome called Evans syndrome, which is a primary autoimmune thrombocytopenic purpura and acquired hemolytic anemia. So a combined syndrome of both autoimmune hemolytic anemia and also thrombocytopenia. And this is the beginning of the paper that described that syndrome. Here we have a list of the past recipients, both the medical student side and the residents of the Evans Award. And to begin our presentations this year, I'd like to invite Ken Steinberg, Dr. Ken Steinberg, Director of the Internal Medicine Residency, to present the Resident Award for the Evans Award for 2022. I'll turn it over to Ken.
Great. Thank you, Conrad. This year, there were a lot of wonderful nominations for residents for the Evans Award, and the committee read all of the nominations and actually had a tough time picking just one person. And so there are actually two co-awardees this year. This has happened occasionally in the past, but there are two people this year to introduce to you. The first awardee is Dr. Roxanne Hicks. And I wanna read to you a short excerpt from some of the nominations for Dr. Hicks. Dr. Hicks is really the total package when it comes to physicianhood: warm and empathic, bright and analytical, conscientious and diligent, and an outstanding colleague and role model to others. She has outstanding judgment, extraordinary compassion, and is genuinely concerned about everyone around her. She's so good at her work. I would trust her to care for family members in the future. I am so fortunate to have gotten to work with her. And that is just one of the excerpts from so many wonderful quotes about Dr. Hicks. Congratulations, Dr. Hicks. The second awardee is Dr. Mackenzie, or Mac Holmberg. Again, some quotes from the nominations for Mac. Simply stated, Dr. Holmberg demonstrates some of the best characteristics of an ideal physician. Dr. Holmberg was exceptionally compassionate to every patient on our service, and I was impressed at the powerful rapport he was able to establish through his genuine curiosity and extraordinary ability to comfort others. Dr. Hicks, Dr. Holmberg, congratulations to you both on this very prestigious award. You are both incredibly deserving, and I'm so proud to be your program director. Conrad, can't hear you.
Thank you. I said we'll now turn the podium over to Dr. Neha Deshpande, who will then present the Evans Award for 2022 to our medical student recipient. Dr. Deshpande.
Thank you, Conrad. On behalf of the committee, I'm so thrilled to be able to announce the student recipient of the Evans Award this year. there were truly a number of outstanding nominations, and our awardee this year is exceptional. I'd like to announce that the award will be going to McKenna Stavins, who was recognized by so many for her consistently caring and compassionate demeanor that was uplifting for her patients and colleagues. One of the nominations included this description of McKenna as just downright exceptional. She truly understands the depth, breadth, and arc of her patient stories, and is incredibly patient-centered in her approach and communication with patients, always sets the highest goals for their health and does not settle for good enough in their care. So congratulations, McKenna. I'm thrilled to announce that you're our recipient for this year, and lucky to say that she'll be joining the primary care track in our UW internal medicine residency program this summer. I'll turn it over back to Dr. Tess King for the introduction of our presenter today.
Excellent. Congratulations, everyone. It's really exciting. I am really thrilled to introduce our Grand Round speaker today. We have Dr. Ryan Abe, who will be speaking today, and I want to introduce her as a friend and co-chief. Dr. Ryan Abe, she, her, is originally from Virginia and grew up in the South. She went to college at Duke University, medical school at the University of Virginia, and moved out west where she completed her internal medicine residency at UW and stayed for an inpatient chief residency year here at UW-MC. She will work clinically as a nocturnist in the Division of General Internal Medicine at UW-MC Montlake starting this summer. Her passion is equity education and building individual and institutional capacity for health equity and justice through a lens of anti-oppression. She is a graduate of the Clinician Educator Pathway in the IM residency program and has focused her scholarship on creating health equity curriculum for residents, including the new Health Equity Pathway. She'll serve as the pathway director for this pathway next year. I am honored to pass it to my friend and co-chief, Dr. Ryan Abe, for her Grand Rounds presentation today titled Towards What Should Be, the Role of Physician Advocacy in Our Practice.
Great. Thank you, Tess, so much for the introduction, and thanks everyone in the audience for being here today. I'm going to pull up my slides. All right, how is that looking?
Looks great.
Perfect. All right, so I'm going to be speaking with you all today about physician advocacy and its role in our practice. I have no financial disclosures. And by the end of the talk today, I hope you all are able to, one, recognize our professional obligation to engage in advocacy for the betterment of our patients, two, understand the spectrum of physician advocacy, and then three, personally reflect on how you want advocacy to fit into your careers. And I know some of you in the audience may have a lot more experience in this in your careers than I do, so I welcome your comments and thoughts in the chat. And then I'll also be highlighting examples of people in our department that I was able to actually interview for this talk who are doing this work so that we can all learn from their perspectives and expertise. So our basic agenda today is going to be to review the what, the why, and the how of advocacy for physicians. So what is physician advocacy? And more importantly, what is advocacy not? I think all of us have likely experienced situations in which we advocate for individual patients by going above and beyond to make sure they get a needed service. However, this is not public advocacy, which would require working to address the root causes of the problems they face in getting ideal care. So our goal instead would be to create lasting change to a system or policy, and then knowledge exchange where ideas are created, disseminated, or shared. And this can happen on the institutional or practice level, or it can happen on the community and system level. Dr. Mark Ernest, who is the division head for general internal medicine at the University of Colorado and a pioneer in advocacy education for medical trainees, he offers this comprehensive definition that advocacy is, quote, action by a physician to promote these social, economic, and educational and political changes that ameliorate the suffering and threats to human health and well-being that they identify through their professional work and expertise. And I find this definition comprehensive but a little bit wordy, so I like this more concise version here. So advocacy is, in other words, leveraging our expertise and experience to achieve broader effect. So how are we at participating in advocacy as a profession? Not to give any spoilers away, but we're pretty bad overall in a few different ways. In studies about physician attitudes, beliefs, and activities around advocacy, it's been found that one, we drop out. Many of us may be civic-minded and engage in some form of advocacy during medical school. However, only about a quarter of us in one survey continue to engage in advocacy during residency. We also don't do a great job of partnering with other healthcare professionals to advocate for our patients. Nurses have actually long been at the forefront of patient advocacy. And the American Nurses Association actually even includes advocacy in its definitions of nursing and its code of ethics for nurses. We don't even participate in the most basic form of civic engagement, which is voting, obviously. In a 2007 cross-sectional study of over 250,000 people, including 1,200 doctors, physicians had actually the lowest adjusted voting rates than any other profession, like lawyers, and even the general public at large, which suggests reduced civic participation. Here's a graph here from that paper. This is a period between 96 and 2002, and across the board, we had the lowest voting rates. And the limited data actually also shows that we may be a little bit selfish in the way that we advocate. One study showed that physicians were more likely to engage in policymakers on issues affecting their own economic well-being, particularly focusing on practice management policy and reimbursement structures. So why are we so bad at advocacy on a broader scale? This hasn't really been studied robustly, but some of the researchers that have investigated how much we engage in advocacy postulate that a lot of barriers exist, particularly in the way that academic medicine is structured. Firstly, medical schools and residencies place, or they at least used to place, heavy emphasis on biomedical knowledge and research as predictors for success for admissions purposes, rather than prioritizing service-oriented experiences. This may have changed a little bit lately, but I think that's sort of the culture that we've been indoctrinated into. Similarly, in traditional academic models where promotion is based primarily on research, grants, and publications, advocacy-related contributions may not be as highly valued. Secondly, I'll say that medical training is, as we know, long and isolating, which often removes us from the larger community while we train. We're also not really we're trained not to talk about sort of quote unquote off limits topics like politics or religion and clinical encounters. This could reduce our willingness overall to discuss systemic issues that plague our patients with them. And then our personal agendas may sometimes conflict with the priorities of the institution that we work for. And of course, it goes without saying that we all have busy and demanding clinical lives, and often we feel that we don't have the time to engage meaningfully in advocacy. So despite these barriers, doctors do engage in advocacy, and many are effective in that role. Their real-life examples really best demonstrate the broad range of physician advocacy, in which I'm going to highlight throughout this talk after having the pleasure of speaking with and learning from these following folks. So firstly, Dr. Helen Jack, who's an acting instructor and clinician scientist and holds joint positions at Harborview and at the Department of Corrections. Dr. Chris Wong, associate professor who works as primary care doctor at the Roosevelt Clinic, and Dr. Nancy Connolly, assistant professor who works as a primary care doctor at Pioneer Square Clinic. So why is physician advocacy so important? And who better to answer this question than Dr. Connolly? And I'll let her share with you why this is so important.
Hi, thanks for having me here today. I'm Dr. Nancy Connolly, a primary care doc in the downtown programs. And I'd like to tell you a little bit about why I think advocacy is such an important role for us as doctors. I started my career in medicine at a Ryan White funded HIV clinic, which had a lot of services, social workers and pharmacists and mental health providers, among others. And I learned from there how important those people were to our patients because purpose, social connectedness, loneliness, housing situation, food availability, these are such important parts of our care for patients and things that we're not really equipped to provide for them. In 2007, we moved to Seattle and I moved to a more conventional primary care clinic that had none of those things, but the patients needed them just as much as my other patients had done. I became more involved in advocacy at that point, working with Doctors for America, looking at the systems that help our patients get and stay healthy, more than medications and counseling and things that we can do in the office.
So as she alluded to, we don't really have as much influence as we think within the confines of a clinic exam room or a hospital ward. Only about 20% of the variation in health outcomes can be attributed to direct clinical care. However, through advocacy, we can influence the other 80%, meaning the policies, programs that dictate socioeconomic and environmental conditions that affect health in our communities, like clean water and air, access to needed health care, and affordable housing. Another issue is also important because non-physicians who don't have clinical expertise or experience are making policies that affect us and our patients. Doctors and patients' voices are rarely heard by legislators and regulatory agencies that set standards and laws for patient care and social issues that affect patient populations. Instead, those regulations are often dictated by insurance companies, lobbyists, and politicians who know little about the realities of healthcare delivery. And we've seen plenty of ramifications of this already. Furthermore, patients want us to advocate. In a qualitative study of factors that influence patient satisfaction, from their perspective, physician advocacy was identified as an important factor for patients. And here's a quote from a patient about why they love their primary care doctor, that she's willing to fight for her patients' needs. And also, many of our governing agencies have deemed advocacy our professional responsibility, including the AMA and the ABIM. And some divisions of the ACGME actually have required advocacy training and experience for residents. And the analogy was made in a paper that I read about this, that even though a small number of us may practice cardiology, for example, every physician must understand the circulatory system and its place in our own area of expertise. And it should be the same way with advocacy. And then with my personal interest in health equity and building curriculum that teaches learners how to analyze the social and structural determinants of health that affect our patients, and how historic and current systemic oppression contributes to this, it can feel really daunting and easy to feel a loss of control, but we cannot be silent. It's been somewhat empowering for me to realize that advocacy is an essential part of dismantling structural inequities that contribute to poor health outcomes in vulnerable communities. So we, as a group, we must address the barriers to advocacy so that it can become an essential and valued part of our work, not just for the physicians, those of us who may belong to those same vulnerable communities, but for all of us. So how can we do better, especially with the seemingly constant barrage of crises recently? And recently, I mean years and years and years. I think many of us can identify and think about a particular health-related issue that we encounter both in our clinical practice and in society that can be addressed with advocacy, like the COVID-19 pandemic, gun violence, abortion rights, racial inequities, etc. So I want to explore with you all how some issues we encounter can be addressed with advocacy. So I chose a case example for us to follow the process, and I hope you can all relate to this scenario somewhat. So say an ICU doctor admits a young woman with a history of type 1 diabetes for severe DKA. She's frequently admitted for DKA and at least every 2 to 3 months, often to the ICU. And it's later discovered that she's actually rationing her long-acting insulin because she can't afford the monthly cost. And so this ICU doctor who's seen this patient multiple times may reach out on Epic Chat or staff message to her endocrinologist, who actually has multiple other patients who are in the same situation, and the patient's primary care doctor feels the same. So the core of how to approach the scenario from an advocacy lens is sort of in 3 steps. 1, defining, so identifying the scope of your problem that's amenable to advocacy. 2, identifying and engaging strategic partners. And then 3, taking collective action after developing a strategic action plan and communicating an effective message. So the first 2 steps of this approach sort of involves being strategic about how we think about power as it relates to both specific issue and systems that actors that play and influence that issue. And actually, physicians, we are actually in a unique position to capitalize on the power of being doctors for health-related issues, because we have higher social standing in society, and we enjoy a degree of access to policymakers, local national leaders, and the citizens and patients. And so we actually can have a great deal of leverage in influencing public processes and priorities. However, given our privilege and positionality, it's important for us to be mindful of the concept of power over, or acting on behalf of the powerless, often our patients, versus power with, or creating partnerships and collaboration with others through collective action and alliance building. So we want to define our issue and our scope, and then figure out what our ask is based on our scope, which goes back to the question of sort of what should be. And we conduct a power analysis based on this. And power analyses help us understand how and by whom power is exercised and who influences decisions related to our issue. So in this process, we think about all the relevant stakeholders and identify champions or allies who can assert their power for change. So for our particular case, our issue may be defined as, quote, the affordability or lack thereof of life-saving insulin. And maybe our ask might be something like passing a law that mandates insurance to cover out-of-pocket insulin costs for our patients. So then we think about sort of who has power, who doesn't have power, who do we have power with rather than power over, identifying our allies who supports us, and then opponents who opposes us. So now we can conduct a power analysis. And I have here sort of on a grid on the y-axis, we have opposition on the left side and allyship on the right side. And on the x-axis, we have people that have more power or less power. So we'll kind of go through some of the stakeholders that may be involved in this particular case. So we have firstly and foremost our patients. Our patients are affected by this problem and issue. They are our allies, but they may carry less power than other players. Secondly, we have, for example, primary care physicians who may carry more power in society than our patients do at times and are also allies in this cause. Then we have our hospital systems. And so as institutions, maybe they kind of fall in the middle and maybe slightly to the allyship side of this issue, but they do have more power in society. And then we have health-related NGOs who may carry some similar power to physicians and are usually also allies in this cause. We have the pharmaceutical industry who likely is on the opposition side and has a fair amount of power. And then we have the insurance companies, which related to our ask likely is in stark opposition to our cause and also carries a fair amount of power in society and the regulating bodies. We have our Department of Health on the state level who likely are slight allies in the cause and have a fair amount of power, given the governmental agencies. And last but not least, the people making decisions for a particular ask, in this case, have the most power, are state legislators. And I specifically put the legislators in this situation as a slight ally in this particular scenario, because given their priorities in this particular state of Washington, that may be the case. But as you can imagine, in a different state, that may not be the case. So how do we build power here? We can capitalize on existing relationships and status in society. And then also I'll say that within groups, there's power in numbers. So if this patient's primary care doctor cares about this issue and makes a fuss about it, just that one person may not actually make much happen. But if she recruits all the PCPs at her institution, or even in her city or state, and also organizes with all the endocrinologists and all the ICU doctors, and then gets a large number of patients on boards too, then collectively they gain power. And if they get nonprofit organizations to back her up, or even the hospitals and their leadership to publicly support this cause, that can be incredibly powerful. And so the message here is sort of that we can build power through partnership and collective action. So in trying to build those partnerships, you may want to know what's already being done about this issue and who is doing something. So say I'm an endocrinologist and I belong to a professional society for endocrinology, the Endocrine Society. And I can go on their website, and most of these organizations have an advocacy arm. So I scroll down and I see that my organization is actually already working on a campaign to make insulin more affordable for our patients. Great, love it. And you may wonder sort of what's the status of this issue? And you may turn to news, media sources for more information. And it looks like there's actually a bill that's coming out. Insulin affordability over time, not doing well. Okay, there's a bill proposed this year that plans to lower the price of insulin in Washington State. Okay, great, I like this. And then the Senate actually has a bill that aims to lower the cost of insulin. Okay, great. So there's already works in progress to address insulin affordability that's already happening right now. And so I pull up this bill. You look at the bill number and you look at leg.washington.gov and read it on the website and see its status. So this particular bill would require insurance companies to cap the out-of-pocket cost of insulin to patients at $35 starting in 2023 and lasting for 1 year. And this is actually an extension of a bill that was passed last year that capped the insulin cost to patients at $100 for 2 years. And there's a congressional work group that was created to address a long-term plan for insulin affordability. And this bill may or may not be acceptable to you. So it's important to kind of look on our websites and kind of see what the status is of these bills. So what next? I've organized some concrete steps that you can take to move the needle for change. And I've arranged them by those that require the least amount of effort, like taking more passive actions, or to speaking out publicly, to ones that take more effort and time, like doing on-the-ground organizing and getting more intimately involved in politics. So we'll kind of go through each of these different categories and talk about the concrete steps that we each can take that sort of may fluctuate based on how much time and effort we would have put in. So I think we all know the easiest way that all of us can influence change is to vote. And I've shared with you already that doctors are collectively bad at this. And so I encourage you all to commit to voting in our local, state, and federal elections. And Washington, luckily, makes it relatively easy to cast our ballots. Just a reminder for everyone in the audience that our Washington State primary is on August 2nd. You can also vote with your wallet by donating to either campaigns, organizations, or causes that are important to you. And building that capital can be really important for a cause. And lastly, you can sign a petition to publicly support a cause or solution to an issue. And next, on this sort of higher level of effort would be speaking out. And so this may involve things like attending a protest, may involve writing a letter to your representatives or congresspeople. And I'll say too here that a handwritten letter actually goes really far and it carries more weight to legislators than just sending a pre-templated email. Although, of course, we're talking about more and less effort here. You can also call them and make your case and talk about how from your personal experience, different bills may impact you or your patients. And you can even write or publish an op-ed or an opinion piece about your issue. So let's go back to our insulin issue here. So I see, okay, here we have a call to action, which is great. So I see that I can be clicking the link to take action and then taken to a form where I can fill out my information and be told then who my congresspeople are based on my zip code. And then also we see here a pre-templated email to those people supporting this particular cause, which seems pretty easy, right? I can sign my name here, press send message. It took me about 3 minutes of time. Though the trade-off is that you may not 100% agree with everything that's in this pre-templated email, but you're free to customize it to your liking. And that's kind of, once again, going back to sort of more or less effort. On the higher effort side of advocacy, we have on the ground mobilizing. You can meet with your Congress people and their staff, which can be self-organized or arranged by a professional society or nonprofit group. You can also give a written or spoken testimony sharing your experience and perspective on a piece of legislature, or you can organize your coworkers to build social and political capital. And if you're a researcher in a field that impacts public health, you can also disseminate your research findings to both the public and policymakers, since publishing journal articles really only has the audience of other scientists and isn't always accessible beyond that. So with this, I'll highlight Dr. Helen Jack's work. So Dr. Jack actually does global health research and mental health. And through her work in Zimbabwe, she collaborated with the Ministry of Health. And for each research project, her team would write a policy brief or a lay language report to distribute to Zimbabwe leadership who may not be as familiar with accessing journal articles. It's important for her to make that information available to people who could most take action. And for example, she had a recent project where she collaborated on a project around implementing a depression intervention in Zimbabwe. In addition to publishing her findings in a medical journal, she also is currently working on putting together a lay language report with her findings to give to public and policymakers. So she says here, there's a real role for researchers to be thoughtful and think about disseminating their findings to people who can make real change. You can also get involved in the plethora of both professional societies, nonprofits, and governmental agencies that are focused on a particular area in their advocacy work. So here, I tried to get a representation of sort of all of our different division societies here. And I'd say particularly for those of us in internal medicine, SGIM and ACP both have advocacy arms for which you can get involved. Furthermore, lots of social societies, I mentioned Endocrine Society as our example earlier, also have advocacy arms where you can either get involved by donating to their cause, by participating in their specific advocacy committees. And so going to meetings, actually pushing policy, looking up different things about our patients in that particular field, and sometimes even going to organized meetings with legislators, either in Washington state or in DC on the federal level. And then on the left side here, I have a couple of different nonprofit organizations, medical societies that are also focused around advocating for patients and advocating to legislators as well. So we have Amnesty International, which is more of on the global health side, the ACLU, which has a Washington chapter, Planned Parenthood, Right Coast for Black Lives. And I'd say too, our King County Medical Society here on the local level does a lot of work around advocacy for patients. And then there's a couple other organizations as well. And it's pretty important to find an organization that fits what your beliefs are and what your priorities are. And I'll say that working with an organization does have the trade-offs of potentially having an organization not align 100% with your particular goals. And so it's sort of that effort cost benefit ratio. If you agree mostly with an organization's stance on a particular issue, it's helpful to have that collective action and have that organization backing a cause to build more power. But if you want to work as an individual, then you may be 100% obviously on board with your own ideas, but it may be harder to get people who are also completely aligned with you 100%. And so I would just say to be thoughtful about organizations that you join. And the more involved at leadership you are with an organization, the easier it is to sort of influence positions on different things. So here I want to highlight Dr. Chris Wong. Dr. Wong became involved in advocacy in his mid-career that was sparked by an interest in pushing for single payer. And he's become involved in leadership with both SGIM and ACP and their advocacy arms. He also spends time thinking about how we can network and mobilize more as an institution so we can work together on these issues. So his advice for you is that you don't have to do it alone, and you shouldn't. So he says here, chances are there are people out there doing what you're interested in, even if not invested in your particular topic. They know who to connect you with. So that's sort of a plug for getting involved in organizations. And that doesn't necessarily need to be an official organized organization, but it could also be with other people at your institution, in your clinic, in your group, those types of levels as well. There's strength, as I mentioned before, in numbers. And so I also want to speak about the most effort, but also the most influential way to advocate, and that's to become directly involved in politics at any of its levels. This could be becoming a trusted advisor to a policymaker, writing legislation yourself, or even running for office. So with that, I'll share Dr. Connolly, who's a great example of this again.
4 years ago, I moved to the University of Washington to work with the underserved and to see if there were other things available to those people who really had nothing. And what I found, of course, was that patients are much the same with much the same needs at different stages along the game, but the policies and systems that affect us all impact our patients. So when an empty seat opened up in my district, I decided I would take the leap and run for office. So in service to my patients, I'm running for office to see if I can change the systems that impact their health and well-being. What can you do? Stay involved with your medical societies. Together, our voices make more of a difference for our patients. Also, write op-eds, letters to the editor, reach out to your legislators, speak at Hill Day. Lots of things that we can do for our patients. And finally, support my campaign. It's very hard to get into office. We don't have any doctors in the legislature, and partly it's because we don't understand, I think, as a whole, the importance of that. So drnancykonnolly.com. So nice to be here today. And thanks for being at Advocacy Grand Rounds.
So Dr. Connolly is an example of sort of the highest level of getting the most involved in politics and running for office. And there are a few physicians in Congress right now and really who understand the clinical things that affect our patients as well as societal structures. And so I think healthcare delivery is something that really takes an intimate relationship with it to understand and make policies that improve delivery of care to our patients. And so I think it's great that we have physicians who run for office and dedicate that. So I'll say also that I'll make the plug here that getting involved in advocacy doesn't necessarily have to mean changing your career or getting additional training or additional education. Doesn't have to mean spending hours and hours of your time doing this. As we mentioned before, with our sort of lower effort things, there are a lot of ways to move the needle on change. And so with that, I want to open it up to the group to say, how do you want to advocate? I want to emphasize here that when we are equipped with the right tools, we can be incredibly effective at informing, shaping, and driving public debates about systems and policies that cause our patients' health to either flourish or fail. So our profession has both an opportunity and an obligation to educate and prepare the next generation of physician advocates, and to commit the resources necessary to do so. So I hope each of you will consider taking a step towards getting involved. And I'd love to hear in the chat, and we can have a discussion and talk about this, like what your thoughts are and how you plan to get involved. I want you all to commit to something. I've also put together some resources that each of you can turn to and refer back to with more information in this advocacy toolkit. You can access this by scanning the QR code. So with that, I'll say thank you and open to having a discussion with everyone.
Dr. Abe, thank you so much. This was a really wonderful presentation, and I love the idea of being able to have some discussion here as well. I will start reading some of the comments and questions in our chat, and please, to everyone listening, post your questions, post your comments in our chat, and we can hopefully open up a discussion here. But before we go forward, I just want to ask one question. I know you've done so much work about increasing the education and experience that trainees get for this advocacy work. And I was wondering, can you just share a little bit about how, like you've been saying, from medical school to residency and forward, the drop off is pretty steep. And so how can we work to increase this work and increase exposure to how to do these things in our training programs?
Yeah, that's a great question, Tess. And I think it's hard because medical trainees often are a pretty transient presence in a community. So there's different ways that we can address this. One, I think institutions really need to invest in faculty that can have longitudinal relationships with community and do advocacy. And then trainees can then learn from those people long term. And that's really important. I think too, also, it's important sort of to have training programs, medical schools, and residency programs in areas that are underserved, where they're really in tune with the needs of the community and can advocate and impact. And those types of people often stay and practice in those places. And so it's really sort of building longitudinal capacity to do this kind of work long term. So it's a tricky situation, but I really think it kind of has to come from top down and have people who are invested long term so that we can train our future generation of doctors to be sort of competent in this advocacy area.
Yeah, and I love the piece you meant, well, from Dr. Wong's perspective about trying to partner with people. I think it kind of goes in line with what you were just saying, and I think such a great next step. And I really love how you kind of emphasize that we can make this bite-sized. We can't all tackle every issue, but trying to really focus on what our specific ask and interest is. So this is great. I just want to read some of the comments in here, and just a reminder, please do put your questions in our chat. But Dr. Hal Stockbridge, he writes, Dr. Abe, thank you so much for this excellent presentation. He says he works closely with the Healthcare for All Washington, HCFA Washington, and we helped pass 22 bills this year in the Washington legislature. All 22 have now become law. This includes the insulin affordability bill that you mentioned. I'd be happy to share more. It's been extremely fulfilling. And then Dr. Young has mentioned that political action committees are super important, and many professional societies have these as well.
Yeah, absolutely. And I think that's too a testament to sort of like, it can be time, money, both, right? So donating to political action committees and causes that you believe in can really make a big difference in helping sort of support the people who are doing the on the ground organizing for campaigns.
We have another comment here discussing their impact or their involvement and impact as physicians working with the health impacts of climate change in Idaho, working with SGIM. And I think there's a question down here. How do we make time to do this? such a great question. And how do we get our academic institutions to give us credit for the work that gets done? That's a great question.
Super great question. I wouldn't say to claim to have the perfect answer for this. I think it is hard. Time is really valuable and critical in our job positions. And I think when I was interviewing Chris Wong about his work in advocacy, he really did say, like, sometimes I don't have time to go to the meetings. And that doesn't mean that I'm not working towards making change, but it's sort of like being able to be flexible with what your bandwidth is and sort of choosing things that are on that whole spectrum of sort of lowish effort to higher effort, depending on what's going on in the rest of your life. But that doesn't mean that it's okay to like do nothing at all, right? Clicking a button, voting, right? Those things don't take a lot of time. And I think the second question here about sort of how to get academic institutions to give us credit for work done, that is the age-old question, right? And I think we're moving sort of in a positive direction at sort of valuing things that are beyond the traditional academic things for promotion. So for example, we're coming up to a vote of sort of placing equity, diversity, and inclusion activities as part of the promotion package that's going to be discussed in our institution and talked about. But I think sort of it varies a lot across the board how much academic institutions sort of value this. And I think a lot of it has to do also with that we need people who are doing this to really like train others, because people might not feel very comfortable sort of getting involved if they don't have experience with this. And we have a lot of people at our institution that I've already highlighted that like are doing awesome work, and so they can be a resource for how to get involved.
There's a question here, a question and comment from Dr. Ralph, and I'll summarize here. But I think he's really mentioning that one of the problems is that the AMA, which is a large organization that many of us know, has been felt to be overwhelmingly have the purpose to protect and increase MD incomes, and the rate of physicians joining that group has been pretty low now. And so the question is really around like, how can we think about a similar organization that would be reconstituted around advocacy for patient needs and kind of bring more physicians back into the fold? And I know you mentioned so many different organizations earlier. So are there any others that you maybe want to highlight or recommend in this similar vein?
Yeah, that's really hard because it's so right that sort of the AMA has sort of a dark history throughout all like the past recent couple of centuries, and their role in sort of creating the structure that we have today that does sort of used to prioritize physician economic well-being, like as mentioned before. And so they're really not, to my knowledge, and if the others in the audience know in the chat, tell me if there's any other sort of unifying national organizations for all specialties, all departments, all roles, like the AMA. Because I feel like a lot of people now, what I hear is that they don't really like identify with the AMA's priorities necessarily, and so they don't really feel comfortable supporting the AMA anymore. And so you're right, enrollment is going down, and maybe that isn't the best organization. They do have a lot of have built a lot of historical power. So it's sort of like the trade-off of like your personal ethics as well as like how much power you're able to build with a old organization like the AMA. And I think potentially options could be sort of getting involved in these like sort of like specialty organizations, but then also having them collaborate amongst each other for particular issues. But it's not a perfect solution, and I'd love to hear like other thoughts, because it's a tricky subject.
Yeah, really good points. I have some comments in our chat here, just emphasizing your inclusion of Dr. Nancy Connolly in your talk, encouraging people to donate money to her campaign. The sooner the better. Sounds like she's doing really amazing work. So thank you for bringing her to all of our attention. And let's see, Dr. Barbara Young again saying, I'm the vice president of the AGA, and we are pushing bills that are supporting colon cancer screening. And they're working on changing the need for pre-authorizations. Amazing.
That's awesome. I'll say too that sometimes for people who have like sort of more radical ideas about how healthcare can be restructured and sort of revamped, it can be sort of tricky to strike the balance between sort of like radicalism versus like incrementalism. Like, am I going to be, if I'm someone who's like absolutely Medicare for all, like I want to completely overhaul our entire system, am I going to be okay with this like one bill that moves the needle like a little bit step in forward? I think that's a tension a lot of people actually do feel, is sort of with like, thinking of what should be, like how our system should work, but then also understanding that our system is really complex and there's a lot of players that are involved. And so sort of deciding for yourself if you're okay with taking that small incremental change, or if you are sort of more on the side of, I'm not okay with that incremental change. Like this one bill about insulin caps is not good enough. We should have Medicare for all, for example. And so I think each person has to sort of reflect internally about what they're okay with and understand that there are trade-offs to either side.
Yeah. As we're talking and as you've been kind of pushing us to think about what our next steps are, I'm thinking about both my own next step and movement to a new institution, and realizing I want to spend some time, learning everyone's role and ability to partner in different spaces there. And I love Dr. Jack's commentary about being able to share research findings and the things that we all read and are exposed to, but in a broader, like out to a broader audience is really great. And I've been working with people on breast cancer screening and equity in breast cancer care. And I think like any other echo chamber, I'm thinking a lot now and wanting to kind of move forward with trying to share that in a more public space and get more people involved. So thank you so much for bringing this out. And I think this is such a great conversation to have, and hopefully more. Oh man, there's lots of comments coming in here. Great comment here that incremental changes can mean a lot to the patient. So yeah, just like you were mentioning. And I don't know if you can see all of these too, I'm sure.
Yeah.
A shout out for an interdisciplinary organization focused on climate and health. Participants may want to join the Medical Consortium on Climate and Health. There was an education and advocacy conference in March that was really great. So that's something anyone can look into if they're interested too.
Yeah, well, this is a good point too here, Tess, about sort of like the commentary about the AMA, like what's stereotypical, sort of, is it worth it to work from the inside of these organizations that have built a lot of historical power, right? Instead of saying, they don't align with my goals, they're like a corrupt or whatever organization, so I'm not going to get involved. Like they are a great option, and I think it's sort of a great point to say, okay, like we need to get involved then. If we want to change this position, we have to participate, right?
Yeah. Maybe changing from within is an interesting way to go too.
Right. And there's a lot of people
Physicians.
interested in the chat. And so I want to so maybe screenshot this and add it to the advocacy toolkit for everyone to have access to, sort of as ways to get involved. This is awesome.
Excellent. Well, I'll give people a little bit more time here to put some questions in our chat if there are any, or any other commentary. But I just want to say again, Dr. Abe, so wonderful to have you give this talk, and it's really such a pleasure to get to moderate a Q&A with you. Once again, after last week, it's wild that we are at the end of the year, but it's really fun, and it's always such a great experience to hear the work of your colleagues and all of the amazing things you've been doing. So thank you for bringing this topic to us. Thank you for opening this conversation. Lots of praise coming into the chat here. And with that, I guess we will maybe end a bit early, which is never a bad thing on a Friday afternoon. So thank you all for joining us. Dr. Ryan Abe, thank you for your great talk, and have a lovely rest of your Friday and a wonderful weekend, everyone. Take care.